Yes, we are recording. I'd like to welcome you all this morning, or this evening, or this afternoon, depending on where you are in the world, to today's webinar. It's a pleasure to have you join us, and we hope that you will find today's webinar interesting and stimulating. It builds on a number that we've had in the series so far, where we've focused on well-being. And today we're going to take a broader view and look at how that might fit within a broader public health perspective. And it's my great pleasure to introduce Dr. Harold Kudler. Harold, as you will have read from his bio, is an adjunct associate professor at Duke University. And he has, in addition to his academic work, he has a long career in working in veterans' mental health with USVA, and in fact has held the position as the chief consultant for mental health services for USVA at their national office in Washington. And so it's a great pleasure to have Harold share with us today from his experience and his work. Before we start, I just mention if you have questions or comments that you'd like to make as we go through, at the bottom of your screen, you'll have a chat function there, a little bubble. If you click on that, you can enter your questions or comments, and we will relay them to Harold as the webinar progresses. So at this point, Harold, I'd like to hand over to you and to invite you to share with us today.
Well, thank you, Robert. Thank you very much. And my thanks to everyone who's attending. I understand we're pretty much covering the globe today. And it's a pleasure and an honor, and I look forward to a conversation with you. The presentation I'm about to give was developed as a grand rounds for the School of Public Health, the University of Adelaide, during the time I had the pleasure of being visiting professor just a few months ago there. You know, as I wrote it, I had no idea how it might be received. In the US, these are pretty novel ideas, although they're growing. And I really relish the opportunity to talk it over now with a even more international group, and seeing where it could go, where it is going, where you live, and if it makes sense. And I've also got a pad out and a pen to take notes from what you say. So I'm looking forward to learning at least as much as anyone else on today's call. So the title of my talk is Clinical and Public Health Approaches to the Mental Health and Well-Being of Service Members, Veterans, and their Families, and Integration. And it really, in many ways, is an effort to kind of take you along the same trail that I've followed in my training and career, and see if we all get to the same place. So let me say a little bit more introducing myself, although Robert did a great job. So I've been a psychiatrist with 35 years experience in the U.S. Department of Veterans Affairs, actually heading on to 36 now. And 31 of those years, I was a clinician for veterans and their families, many special forces folks, enlisted, some officers. We don't get as many officers in the U.S. Department of Veterans Affairs. They often go elsewhere. I spent 4 years in Washington from 2014 to 2018 as the policy lead nationally for the U.S. Department of Veterans Affairs mental health program. And in that capacity, worked with opposite numbers in the U.S. Department of Defense, and also with people from other nations as well. Most of the time I spent in the VA has been in the state of North Carolina, which is sort of midway between Washington, D.C. and Miami, Florida, for those who are trying to figure out where that might be. But what's particularly important about that is North Carolina is one of only 4 states in our nation that has significant bases by all 4 branches of our military, plus our Coast Guard, which officially is not part of the Department of Defense. It's a part of Homeland Security. Among those places, 90 miles from where I'm sitting now, is Fort Bragg, home of our nation's largest military base and home of the most frequently deployed rapid response unit, the 82nd Airborne, as well as U.S. Joint Special Operations Command, JSOC. So it's a particularly rich environment to be working in the VA and reaching out to Department of Defense, DOD, as we call them. And also in close proximity to Marine Camp Lejeune, which is the second largest Marine base in the United States. And its expeditionary force deploys every 6 months, rotating with the Marine Expeditionary Force based on our West Coast in Camp Pendleton. We also collaborate through VA with an infinite number of community organizations, local, state, and federal. And one of my more interesting experiences was from 2000 to 2005, beginning before September 11th, 2001. I was chairing the VA's Undersecretary's Committee, Special Committee on PTSD, which reports to Congress on clinical care, benefits, research, and education across the VA regarding PTSD. And many of you know the United States Department of Veterans Affairs has a huge research and clinical program on PTSD. We collaborate with many other nations through this. It was really quite something. On September 11th, 2001, I was doing my clinic. In fact, I was doing a telehealth clinic on a machine much more primitive than the one I'm talking through you now on. And a Vietnam veteran with schizophrenia and PTSD and I were having a conversation when the head of that vet center program where he was stationed, I'll talk more about the vet centers later, in rural North Carolina, broke in and said that a plane just crashed into the World Trade Center. Being a native New Yorker, frankly, I know that planes crash into tall buildings in New York from time to time every few years. And, you know, I wasn't thinking anything sinister about it, but he came back when the second plane crashed and I had the abrupt understanding that, if I'm the co-chair, at that time the only co-chair, of the Undersecretary's Special Committee on PTSD created by Congress, frankly, because they were worried that our VA would forget PTSD as we got away from the Vietnam War, as the World War II veterans were dying off, that the VA would sweep PTSD under the rug. And so they created this committee, recreated it really. It had been dormant for a number of years to make sure it didn't get forgotten. But suddenly we found that we were going from a retrospective view of what PTSD is. Let's catch up with those Vietnam veterans and those World War II and Korean War veterans and Gulf War veterans before they died, if they'd like to be caught up with and when they feel like coming to see us. Turned into a prospective, we're going to war, we're going to have a new generation of veterans. We had no idea how big or how long that war would go on, and it's still going on, not officially, but it is. Now we had to have a prospective approach to PTSD, preventing it whenever possible, and working closely with the Department of Defense on that, an entirely different mission. It's experiences like that in the course of my career that lead me to where I am today, to think about what resources we have, what do we know, who are our partners, how do we connect with the people we're supposed to be serving and their families, who we can't treat these people in a vacuum. Now we look at suicide. So we'll talk more about all this. So on to the next slide. Actually, that was the next slide. I failed to give you that just as well. On to the next slide. Let me now introduce the United States Department of Veterans Affairs. And I want to be clear, I'm going to give you some very big numbers. And I know when I was in Australia, I think there was a real danger that people would say, oh my gosh, you know, your numbers, your size is very different than ours. What you're saying probably isn't relevant to what we're doing. It sounds like you're on a different planet. As a matter of fact, the proportions of the problems and the populations that we're dealing with are very similar to what we saw in Australia. And I suspect they're similar to other nations. In fact, I look forward to hearing about that from you. But the United States Department of Veterans Affairs has three components. The first is the Veterans Health Administration. That's the part that delivers healthcare. And that's the part that I primarily have worked with. And frankly, most people who work in the Veterans Health Administration, like me, working in VA medical centers, often don't even know the other two parts even exist. We are that separate. The other group, the second of these groups, is the Veterans Benefits Administration, once an entirely separate agency with its own history, most of it going back to the American Civil War. And they manage a range of veterans benefits, from mortgages to educational benefits for veterans and their family members. And we'll go into that a little bit more later and kind of explain why that is and how that works into what we're talking about today. And finally, the United States Department of Veterans Affairs runs the largest cemetery system in the world, the National Cemetery Administration. We are a very comprehensive agency. Let's say a little about VA clinical services. Veterans Health Administration, VHA, has 170 major medical centers, and these are significant medical centers in states all across the United States and as far away as Puerto Rico and even Guam. We try to be where veterans are. We have over 1,070, almost 1,100 community-based outpatient clinics. Many of these clinics are on the small side, having only primary care and mental health. By definition, every one of our outpatient clinics at the least has to have primary care and mental health programs. But many of these outpatient clinics are basically hospitals without beds. They have everything, including very sophisticated imaging, rehabilitation programs, et cetera. And when we say mental health in our program, we mean mental health and substance abuse. So that a lot of programs, those are separate entities, sometimes even separate departments in many states. But mental health and substance abuse in these outpatient programs. In addition to these formal medical programs, we operate 300 vet centers. The vet centers were a Vietnam generation idea, although they didn't open officially till 1978. And the idea was that in the 1960s and early 70s, as Vietnam veterans came home, tried to readjust without anybody's help, and found or were told by their family members and coworkers, bosses, that they had a problem that they didn't want to think they had, and went to get help, they'd come to the VA medical centers. The VA medical centers at that time were primarily thinking a veteran is a World War II veteran or Korean War veteran. A veteran's an old man for the most part. A veteran looks a certain way and has a certain kind of problem, and they certainly don't have this PTSD stuff. And when Vietnam veterans would start to come to VA facilities, looking young, having a different set of problems, and having this PTSD stuff, a lot of VA medical centers basically gave them the cold shoulder, and that was received, and these folks turned away from the VA, and many of them never came back. Having created that problem, the VA in the late 70s realized they had to somehow engage these same people that they had disengaged from, and they created the Vet Center program, which grew to, at this point, 300 formal centers. These tend to be storefront operations. The VA rents space in a strip mall, in a community with good bus service, on the bus line with parking. It doesn't look like a hospital. It's staffed, for the most part, by psychologists, social workers, and peer specialists. And these people, even the social workers and psychologists, 60% of them are veterans, usually combat veterans themselves. And these programs are not treatment facilities per se, although they deliver a great deal of care, including evidence-based psychotherapies, supportive therapies, help with vocational assistance, things like that. But they also do group and individual therapy, and they do a lot of just hanging out and talking with people. They open on weekends, they open in the evenings, they have programs for families, and the idea is to engage in any way they can. During these recent wars, starting in about 2002 or so, the vet centers were given the authority to hire now 100 what were called war on terrorism outreach workers. These were newly returned veterans from Iraq and Afghanistan without any formal training, but who wanted to work with and serve other veterans and help them with their readjustment. And the VA provided training to them, which really, kind of the silver lining to all this is, before September 11, 2001, the vet centers were primarily staffed by Vietnam veterans themselves. And those Vietnam veterans were beginning to age out and retire. And a lot of us in VA were very concerned that the vet center would collapse because there wouldn't be any combat veterans to staff it. These young global war and terrorism outreach workers, GWAT workers as they were known, have been brought along. Many of them have taken on additional training, which the VA has paid for, to become social workers and psychologists. And for better or for worse, we're now equipped to get on for the next 20 or 30 years with peer support people, including mental health professionals who are combat veterans used to working in a combat veteran program. We also have 80 mobile vet centers. The mobile vet centers can go anywhere, rural areas, urban areas. They go to sites of disaster and serve virtually anyone at an earthquake, at a mass shooting. It's something the VA does to engage people, and we know that veterans are everywhere, so we feel right in doing that. They each have satellite communication systems, so even if our hospitals, for the most part, went down, these satellite systems would allow them to communicate from point to point virtually anywhere in the nation, and they can do everything from setting up a clinic on site to evacuating survivors. The VA has also hired over 1,400 peer support specialists. These are veterans, almost always combat veterans, who then take a certified training course and provide unique engagement and support, both in our medical centers, in the mental health clinics, in primary care clinics, often sitting in waiting rooms and engaging people who look restless. And I think most of you are clinicians know that there are a lot of people who look restless in our waiting rooms. But doing outreach in the community as well. And I'm very proud to say that VA has fully accepted the importance of peer support specialists and the unique mission that they're capable of achieving that many doctors really aren't good at or aren't placed in a way they could do it. Finally, we have the Veterans Crisis Line. 4 years ago, now I guess it was 2014 when I moved to central office, there was one site for the Veterans Crisis Line in upstate New York, a sleepy little place that would have closed if they hadn't decided to keep the lights on by placing the Veterans Crisis Line there. We now have 4 centers, and they're not nearly enough. They field, I believe the number I heard last week was over 2,000 calls every day, and they answer that phone in 8 seconds or less. They can project help to any point in the country. They literally can identify where a veteran's calling from and send, if necessary, an ambulance or the state police to find them and rescue them on a mountaintop in rural Tennessee. And they do it, and they do it every day. It's a remarkable program that connects veterans in crisis and their families and friends with qualified. And these are truly caring professionals and first responders. If you follow the US news, and I don't know why you would, but if you do, and maybe you face this in your own nations, I'd be interested to hear about that. A lot of people, well, in our country, you may know in our presidential debates going on now, don't believe that the US government can or should do healthcare. Whereas in your nations, for the most part, there is national health in some form, and it's an accepted idea, and it works. I know it's not perfect for anybody, but it works. We're still afraid of it here in the US, and it's one of the major debates in our elections for the last many years. And sometimes people will raise the question, well, VA is government healthcare, and by definition, it can't be good. And in fact, when President Obama said the government can run a healthcare program, and the VA is the proof of it, and gave a lot of reasons why VA was a very good healthcare system, his political opponents spent a great amount of money and time to prove that the VA must be no good at all and that you shouldn't trust anything they say or do. So I'm sharing with you here our 2018 report from the National Academies of Science, Engineering, and Medicine, formerly known as the Institute of Medicine of the US. Very distinguished group of experts chartered by Congress to deliver neutral, kinds of expert reports. And their report concluded that the United States Department of Veterans Affairs provides mental health care to veterans of Iraq and Afghanistan wars of comparable or superior quality to other providers. And in fact, as you read that report, it gets back into research we've done in the VA and research with the RAND Corporation, one of our major sort of think tanks, that government and industry reach out to explore different questions and make recommendations, they've pointed out that across the US, most veterans are being seen by people who don't even know they're veterans. And if they did know they were veterans, these are providers who know very little about military culture, very little about the kinds of risks, health risks that follow veterans and their family members before, during, and after deployments and through the rest of their lives, and really don't feel comfortable engaging them. Not only don't have the clinical and cultural competence, but they lack confidence in being able to provide that, which I believe is the major reason they don't ask people, have you or someone close to you served in the military? And the vast number of American veterans are being seen by providers who fit that description, something we'll get to a little bit later. There are, in fact, 9 million United States veterans of a total 20 million living United States veterans who are enrolled in one way or another in VA healthcare programs, but only about 6 million use them actively. I say only 6 million because it's a lot less than the 20 million living veterans. So in practice, really only 1 in 4 living veterans uses VA mental health care annually. And this, we believe, is a real access problem in terms of meeting the real needs, and particularly dealing with veteran suicide. More to be said about that. By the way, I was impressed that in Australia, even with a very robust national health system, only about 1/3 of their veterans are taking advantage of the Australian Department of Veterans Affairs healthcare programs, part of which includes special access to resources that the average Australian doesn't have access to. And again, I saw that as an important parallel to our situation, that veterans have resources that they either don't know about or choose not to access. And as somebody who's tried to do healthcare planning, not that they taught us in medical school how to do that, but in the School of Hard Knocks, we were supposed to figure out how to do that. That to me is a major problem to be solved, and one I look forward again to discussing with you folks. So one thing I can say about the Department of Veterans Affairs that I think is an extremely good thing. I'm very proud of the people where we work, but I want to present it to you, warts and all, and the concerns that I have. We are the nation's largest integrated mental health system, which means that if you come to the VA, you're going to get primary care integrated with mental health care. You're going to have mental health embedded in primary care settings. You're going to have teams that talk about the case, any given patient, from both perspectives, and share and teach each other and help support that veteran. In 2017, more than 1.7 million veterans received care in a VA mental health program. That's the 1 in 4 I was talking about. And by the way, that number has nearly doubled since 2006. So we're doing much better in making care available, and I think making the case that we can help. Whether you want to think about yourself as having a mental health problem or not, maybe we can help you. And nearly 1/3 of the patients that have received mental health care from the VA have received it from a mental health provider who is actually based in a primary care clinic. The integration of mental health services directly into primary care clinics, not down the hall under a sign that says mental health, where you're worried that your friend or your friend's husband or wife is going to see you walk down the hall under that sign, or sitting in that waiting room, and you don't want to be seen, especially if you're, say, a member of our reserve units or National Guard, and still expected to deploy and still have a security clearance that you're worried about losing because someone thinks you have a mental health problem and maybe shouldn't be carrying a weapon or have a responsible position in the military. Among the things that the integration helps us with is the idea that instead of a primary care doctor saying, you know something, I think you ought to see a mental health professional, I'll get you an appointment in, it's in 3 weeks from now, why don't you miss another day of work and drive between 1 and 6 hours to get here? Instead, they can say, walk down the hall and meet my colleague right, next door over, who's a mental health person. There's no question that this person will be seen on the spot, will get the help they need, and will now be engaged. and will never have had to walk under that sign, mental health. We can show statistically this is largely responsible for the increased engagement with mental health we've had over the last few years. It also provides an opportunity to identify, prevent, and treat mental health conditions at the earliest opportunity. The VA has our nation's largest electronic health record, and that health record, even though it's very old, is a legacy record. We're in the process, a 10-year process of buying and implementing a new one, which will be it's the same one the Department of Defense used. So these things will be totally interoperable, and we'll be able to follow a person from the day they enter the military throughout their entire life afterward through our systems. By the way, we'll be able to make that system available to outside providers if they're working with that veteran, if the veteran signs a release for it. It's a remarkable tool. And one thing we've integrated right into it are screening tools for depression, for suicidality if you score positive for depression, and for PTSD. You also get screened for suicide if you score positive for PTSD because of the increased risk. Got to tell you, when I was the co-chair of the Special Committee on PTSD, I went to the committee that looked into screening and approved screening measures. And it took me about 4 years to convince them it was a good idea, being the VA, to screen for PTSD. Their report was, well, we already do too many screenings, and that's just another pain in the neck for everybody. They didn't quite understand that being the Department of Veterans Affairs with a mission to serve veterans and thinking about what veterans do, we had a responsibility to think about PTSD more than in the public sector where most of these guys are trained. And the other objection, which was an interesting one from a scientific perspective, is, well, we don't think you can treat PTSD. And if there's nothing you can do to treat PTSD, why would you identify it? That's a waste of everybody's time and actually creating more grief than you're resolving. And of course, I didn't think that was true. And it's certainly less true today than it was almost 20 years ago. Let's keep moving forward. But all this is part of the idea of early identification, prevention, and treatment. So let's go back to 2002. The Special Committee on PTSD, looking at the problem of being a nation at war and the need to prospectively do something about that, said, well, you know, for better or for worse, we have a hell of an opportunity to gather data that we never had for past wars. And I got to sit down with the undersecretary when he met with the head of our epidemiology unit in Washington and said, you're going to start gathering data and you're going to report it quarterly, and it's going to be reported to everybody. It's going to be on an open website, and everybody's going to be able to see it and use it for research, for planning, etc. This research, it's hard to find, but it's still available on the VA website by quarters. It was clocked from 2002 until the second quarter of 2015, and it includes information on over 1,189,709 people who returned from Iraq or Afghanistan during that time. It's called the Post-Deployment Health Group, the website you can Google for to get this stuff. And it looks at, and I'll apologize for not spelling this out, I think many of you know this, OEF is Operation Enduring Freedom. That is our combat operations in Afghanistan. OIF is Operation Iraqi Freedom. That's our combat operations in Iraq, officially over, and now Operation New Dawn in Iraq. Whatever it is we're doing, peacekeeping, training, and occasionally combat, is now Operation New Dawn. So we have all this data. It's an immense amount of data. And by the way, data use agreements are possible to look at this data, compare with your findings, and use for your own research and planning. I'm always very pleased to give away VA's resources whenever possible, but everything we do exists in the public domain, plus our epidemiology people are pretty good at sharing this stuff. You know, there are forms to be filled out, but it can be done. What the data indicates is that service members, veterans, and veterans encounter significant problems engaging with VA and presumably with other systems of support, medical and non-medical. Almost 60% of the veterans that came through this system out of Iraq and Afghanistan and came to the VA received a mental health diagnosis. It was the second most frequent diagnostic group, the most frequent being musculoskeletal injuries, although the single most frequent diagnosis was hearing loss / tinnitus, or depending on where you train, tinnitus. And And it was interesting. I had noticed this, and a friend of mine actually graphed it out, that every quarter, if you graph out the percentage of and number of mental health diagnoses per quarter, and these are working diagnoses, but they, in looking back, they tend to be to play out true to form. They are effectively diagnoses for mental health problems. That the rate at which people get mental health disorders goes up every quarter. So in other words, you know, not just the total number go up, but the rate within the group that's already come that quarter is higher than the group that came the quarter before. And I think this represents, again, people began to think about PTSD. I remember in the Gulf War when a lot of our veterans came home and said, I don't have that Vietnam stuff, don't pin that on me. I think that the idea about PTSD is much more acceptable to veterans and their families, and they come looking for help much earlier if they think they might have it, and often they do. Traumatic brain injury, of course, became another one of these things. Substance abuse problems were high on that list. Depression, various anxiety disorders, things you're all very familiar with. And efforts to enhance VA healthcare enrollment were successful, we found, in accelerating the utilization of VA care. And my point in sharing these slides is that our first step in preparing for the impact of these new wars was to develop this data system to capture signals arising in our clinical programs and follow the slope of those curves so that it would allow us to project needs and build the appropriate capacity. Looking back, there are a lot of lessons to be learned about how we went about doing that and which parts actually were helpful and which parts were not helpful. And maybe we'll talk about that later too, or it could be a lesson for another day. Let me take you forward to 2003 to 2005, where it began to dawn on us, and certainly on me, that we needed a new approach. As late as 2005, I know that my head was still in the clouds somewhere. I really believed that we had lots of clinicians in both the Department of Defense and the VA, lots of expertise on PTSD, that we could provide effective treatment. And we simply had to figure out how to get those veterans into those clinics so they get the help they needed. But our data, the data I was telling you about, showed that both in DoD and VA, while we were focused on bringing them into our systems, the majority of these veterans weren't coming. I'd say by 2005, maybe 40% of everyone who had served in Iraq and Afghanistan at that time had ever come to the VA for anything, whether to get their feet looked at or to talk about a mental health problem. If they came to get their feet looked at, the odds are we'd screen them for a mental health problem and get them into treatment. But less than, the silent majority were still not coming in 2005. And our secretary, along with the Secretary of Defense, decided that they would sponsor the first joint DoD-VA conference on deployment mental health. And I remember telling my opposite number in DoD, because I co-chaired it with her, all we got to do is map out all our resources, all our clinical programs, figure out how to get the veterans into these things, and we'll be done. Well, job done. And she looked at me with pity, and it's still an embarrassing memory, but she was absolutely right. My consciousness had not been raised, but that's why I'm here to talk to you about this now. During that period, we also developed at my VA and in my network, my one of 20 local networks across the United States, we created a VA research, education, and clinical center on deployment mental health, which now sounds like a perfectly reasonable thing to do. But I remember when we did it, the head of mental health at that time came to our first site review and said, well, it's great you're doing this now, but what are you doing? The war is over, your job's over. Without really the top leadership of the VA didn't really understand that, well, this should have been in VA from the beginning, and the tail of these wars is a lot longer than the wars themselves, and in fact, it's lifelong for those who've served. I'm not saying they're all going to be broken. I hope you know that that I don't think that, and that I'm sure you don't think that. But for many people, that impact is going to be something that we need to be mindful of and ready, should it impact them later in life, as it often does. Also in 2005, that was a banner year here in North Carolina, we had the first meeting of the North Carolina Governor's Work Group. And in fact, let me go to the next slide about that. The Governor's Work Group started in December of 2005 with 6 people meeting around a table in one of our state offices. What had really happened was that our governor decided he'd like to get reelected, and that 1 out of every 10 people in the state of North Carolina is a veteran. That includes men, women, and children. And maybe it'd be good if he did something good for veterans, which, you know, was a good idea anyway. And he wanted to get reelected. And he now directed his offices, which included our North Carolina National Guard unit, to cooperate with anyone who'd like to work on this with them. We created a big tent coalition because we really didn't know what to tell people what to do. We decided we would collect everybody and see what everybody was doing and what they thought ought to be done, and then see what was doable together. This was basically a Department of Defense, VA, state and community partnership. And as I say, in North Carolina, we had the Army, the Air Force, the Marine Corps, the Navy, all having bases in our state, most having major medical facilities in our state, and the Coast Guard, plus Guard and Reserve units. Our coalition, in its actions and interests, ranged from homelessness to prison systems, veterans in prisons, vocational rehabilitation programs, local school systems where the children of these veterans were going, and which were dealing with deployment stress in the children. You know, during these wars, the rate of psychiatric hospitalization of military children, as I recall, finally tripled. I remember when it doubled, and I believe it ultimately tripled as these kids were dealing with various kinds of stress. And a great many more kids then got hospitalized psychiatrically, were having problems in school, and often it appeared in things like fights, truancy, grades going downhill, or other such things. Issues like financial literacy training, support for veterans enrolled in higher education, and programs that paired veterans with service animals. But these were just a few of the kind of things we've gotten into. I'm very proud to say that in North Carolina, we've been meeting monthly since 2005. The meetings are now chaired by senior VA VA health and benefits leads, state government officials. Some military officials are still doing this, employment leads, homelessness leads, and that in many of our calls, most of our calls, we have over 5,000 virtual attendees in these monthly meetings, as well as 75 to 100 in-person attendees. I heard that 12,000 people attended a recent meeting on deployment stress. You know, at the very least, I believe this has helped us weave a much finer web in North Carolina that makes it much harder for service members, veterans, and their families to fall through, because we really do know each other, and we trust each other, and we know how to get a hold of each other. So let's take it further. From 2006 to 2013, our mission and our vision shifted. We realized that we needed to assure that service members, veterans, and their families are recognized and have access to military, culturally competent, and clinically competent care when needed wherever they seek care or support. We called this a no wrong door approach. And this came out of those statistics which kept showing that most veterans still weren't coming to the VA. And even as we're getting toward, all right, 51%, 52% now, as I mentioned, 60% as of 2015 were coming to VA. A great many of them were also being seen simultaneously by their local doctors for other problems. And those doctors still didn't know they were veterans, nor did they know they were in the VA, nor did they know what medicines, I think, very often they were getting from the VA. So we had fragmented and potentially very redundant and dangerous kinds of too many cooks medically. In 2013, I was invited to write an article for a special issue of The Future of Children, which is published by the Brookings Institution, a major think tank, and Princeton University. They publish this journal, Future of Children, several times, a couple times a year, I guess. Each is a special issue. And this one was called On Military Children and Families. And one of the co-editors is an Army psychiatrist, works with Bob Ursano. Many of you know Bob's work at our Uniformed Services University, which is the military medical school for our nation. And Steve Koza, the West Point graduate, child psychiatrist, former head of mental health at our largest, Walter Reed, our largest and leading military health program, asked me to write a chapter which he called Building Communities of Care. And I said, what do you mean by building communities of care? And he said, Harold, that's what you told me about North Carolina. You write the chapter, you figure out what it means, and you write it because you keep telling me we need to build these community systems. And I joined up with Army Colonel Rebecca Porter, who was doing something similar in the military. And by the way, Becky Porter just recently left the military, retired, and is running the Military Child Education Coalition, a national group looking at military kids and trying to reach military families through their military kids whenever possible. We wrote this chapter calling for a public health approach that goes beyond clinical models, that focus on service members, veterans, and their families as individuals, and which harnesses the strength of the communities which surround them. This is a very different perspective. And actually, this first dawned on me in that meeting back in 2005, when I realized we were never going to simply have enough clinics and enough referral systems to get people into those clinics. We needed a public health approach. And I remember saying to the audience one morning, as we did the opening session, it was like a 4-day meeting, what worries me is that this isn't a clinical approach we need, it's a public health approach. And I don't know anything about public health. And looking around this room, I don't see anybody else who seems to know anything about public health either. So I think we have a problem. I don't think that changed a lot in the years after, although I think a lot of heads nodded. The spectrum of a public health system would have to span from schools to community clinics to colleges, workplaces, religious institutions, legal systems, courts, and veteran service organizations, and well beyond. The article, and I provided you, and Bob can send you all the slides, and the link is there. The article, which is in the public domain, is available. And this journal, this edition of Future Children, is the best compendium I know about research on military children and their families. So I recommend it on many counts. And the article reviews a broad array of programs, public and private, that build on these communities of care and describes new initiatives that break down barriers between agencies to do that. Now, the core idea of all this is that communities of care, as a quote from the article, are defined as complex systems that work across individual, family, community, military, state, and national levels of organization, note the British spelling, to promote health and well-being. An effective community of care can be measured by its public awareness of service members, its ability to recognize their needs, and to support them in community settings, and the ease with which service members, veterans, and their families can access resources and services. This has gone, by this point, well beyond what I was trained to do, which is a patient walks into a waiting room, waits for a while, sees me, and I provide a thorough medical evaluation, assessment, and treatment plan. This is something very, very different. And again, for me, the irony of this is that our health system was entrusted to people like me who trained as clinicians, and it hasn't for a very long time been led by people who think about public or population health. So as an example of a public health intervention that we developed in North Carolina, we conducted over 50-day-long trainings for health professionals and program leaders across our state. Ultimately, we trained over 20,000 providers through a nationwide grant to make them culturally and clinically military competent. We worked with our national system that is involved with Medicare and Medicaid to develop a funding code so that doctors could be paid for taking a military history. We thought maybe money would help them get around to doing that. I don't think money has solved the problem, and plus many of them still don't know this exists, so we're now engaged in a public information outreach that this code does exist and you can be paid for doing it. The majority of civilian providers and health systems at this point across the US still don't ask the question, have you or someone close to you served in the military? This program, Painting a Moving Train, which is a quote from one of our Marine generals who said early on that trying to catch up with these wars is like trying to paint a moving train, was meant to alert civilian providers, educators, employers, and congregational leaders about the signs of deployment or transition-related stress. And I think it was I think it was very effective. I'm very proud of training 20,000 providers. But I have to say, when you think about a national system, training 20,000 providers did not move the needle one tick. It was a great deal of work. It was a very good model. But this by itself could not be the mission if we're at the national level. Well, it also connected civilian support systems with DoD and VA healthcare. We enrolled people in our TRICARE system, which treats veterans and their families and many military people away from military treatment facilities. But let's keep working. So we had to enlarge the scope from the patient in my office to military and veteran families. And while, you know, I've always been a great fan of working with families, and I think it's very important to engage any part of the family that would like to be engaged. And especially if they happen to be in your waiting room, I always engage them with the help of the veteran and the permission of the veteran to do it systematically. Realizing that military families face predictable stressors during the deployment cycle, which includes pre-deployment, deployment, post-deployment adjustment, when they start new families, when a family breaks up, during new postings, and finally during transition from the military. So now, but this is also unusual for our VA. Our VA has a very small family program, pays lip service, has some truly dedicated family advocates, but for the most part is not a family conscious program. And this is something we had to work with. And it's for problems like that I decided, well, I'll go to Washington. The job was open to run VA mental health policy, and what the heck, I'll you know, if they'll take me, I never thought they would. I'll go and I'll go there. I promised myself 4 years, and that's what I did. So during that period, I was the national policy lead for VA mental health, and I learned a great deal. I learned about programs I didn't know existed. I worked with wonderful people in the US and abroad, and I'm going to try to summarize that. As I tried to respond to longstanding issues, including the crisis of the day, often some newspaper article that I had to deal with, and put aside everything else I was doing, I became increasingly aware that in the aftermath of World War I, so 100 years ago now, our US VA, and this turned out to be true of Canada, of Australia and Canada, and I imagine your other systems as well, our VA had been originally conceived in the 1920s as a population health system, and it was deliberately designed to provide not only high quality militarily, culturally, and clinically competent care. And you know, I can find you quotes from the 1920s where military doctors who began to advocate for veterans said they can't get this care from community doctors they know nothing about. Service in the military, service in combat. We need to roll out this training across America. But there also needed to be a focus on prevention, resilience, health, and well-being across American society. And frankly, there had to be an awareness that there will be a next war. But this vision, which got off to a fairly healthy start in the 1920s, at least in the US, eroded over the past century as our public health vision kind of slowly turned into a purely clinical model of care. So I began to realize that the people I was meeting with, when we'd have national meeting of directors of medical centers and of regions of medical centers, these people thought of the VA and of their jobs as delivering the same care you'd get in any hospital in America, only there'd be a few bells and whistles that were veteran and military, just a few things, a little more TBI, a little more PTSD, but basically a hospital is a hospital, a doctor's a doctor, a patient's a patient. And that missed the entire point of inventing the VA, to be something quite other. We'll get into this a bit more. For me, the futility of a purely clinical approach, you're a patient, I'm a doctor, we'll do what doctors do with patients in a hospital that is like any other hospital. The purely clinical approach was going to fail. And this was made clear by our efforts, which became President Obama and then President Trump #1 veteran health priority, to end veteran suicide. But it was shown that of the 20 American veterans who on average die by suicide every day, only 6 of them were in VA care, at least not in the last several years. By the way, just last week, I learned that these numbers have been updated. That 20 veteran number, which we had, actually reflects service members, active duty service members as well. It's really now 18, but it's still 5.4 veterans. Only 5.4 veterans of the 18 who die on average every day are in VA care. So stick with my old numbers. If 14 of the 20 US veterans who die by suicide every day are not getting their health care within the VA system, it doesn't really matter how large or how good the VA clinical care may be. I can quote all sorts of experts and say what a great program we are, and I can feel really good about it. But it doesn't matter because they're not in it, and therefore that system isn't going to solve this problem. And that's what really came to haunt me in those 4 years in Washington. So to me, the message was what was needed was a population health approach to veterans' mental health, not a better clinical approach. We had a pretty good clinical approach. It could always be better, but a population-based approach. And a population health system meets the needs of its target group wherever they might be, in whatever terms they might need. We don't make them get in the lines that we preordained to wait for the services that we told them they ought to have in the terms that we wanted to offer them, which is what we've basically done. This is why VA became a leader not only in health services, but also in providing benefits back in World War I, but also in providing benefits like putting veterans through college, providing low-interest government-backed mortgages to enable veterans to become homeowners and build wealth while enjoying housing security for themselves and their family, and providing vocational training and employment assistance, among other things. Occupational therapy was all but invented during World War I and afterward. I've had the pleasure of walking through the British Imperial War Museum, and that was one of the most impressive things, the occupational therapy movement that they held, and we had that in the US, and I know you had it in Australia, and I expect in New Zealand and other places that I haven't had the pleasure of visiting. Yet, VA healthcare systems now have fallen into a reactive mode, reactive to disease, rather than proactive to prevention and health promotion. We are a sickness system rather than a health system. If you see me, you have to have already decided you might be sick, and I'm going to talk to you about your illness, not about your health. So I've generated this clumsily, but you know, this is my effort to represent what I'm talking about. If we were to develop a population health approach to preventing veteran suicide, we would want to start with the veteran, make them the center of our attention. And that system would have to be driven by the veteran's needs and preferences, not ours. And as we began to mobilize to meet the need of veteran suicide, really ramp up our system, we built the system I was telling you about. We built hospitals. We built the vet centers. We multiplied the numbers. We built clinics. We built the clinics all over America with the aim that no veteran would be more than 30-minute drive away from any. That's not totally successful. If you live in Montana, you might drive 4 hours to get to one of these. But for most Americans, veterans can reach these within 30 minutes. And then we built the crisis line for people who couldn't get there fast enough or needed to be seen or spoken with that minute. So we thought, within the realm of building a health system, that we had surrounded that veteran with care. And then as we realized there were all these veterans dying by suicide anyway, no matter how good our health system was, we began to look for veterans in other places. We went to colleges where we were paying veterans to get college education. So, you know, they were accumulating there. Let's go find them. We went to workplaces. We worked with employers. We worked with employee assistance programs. We put out notices in employee magazines of large and small corporations, many of which share the same information. So, this was pretty effective. We went to the legal systems, finding veterans in jail, veterans who had been arrested. We diverted people who were arrested from jail into treatment wherever possible. We trained judges and district attorneys and defense attorneys and created a system that's now nationwide of veterans courts, which are a wonderful model. We went into congregations and did outreach with rural and urban clergy members and lay leaders not to become psychiatrists, but to identify veterans in their community as just a simple act of justice, of saying, we welcome you and we recognize your, what you've done for the nation and the community, but also to recognize when there are problems and just be able to point to the right help if people were having problems. We reached out to veterans organizations and homeless programs. Veterans homelessness, half the veterans in America who were homeless at one point, half the people in America who were homeless at one point were reportedly veterans, and many of them with mental health problems that contributed to their homelessness. So we reached out to these populations, and that was an improvement, and I was proud of that. But that still was thinking like a big hospital system that wanted to reach into these populations and these sites for the mere purpose of getting them into treatment, which often wasn't effective, and frankly, I think would be insufficient even if we succeeded. We also began to identify populations like special forces and rural veterans and Native American veterans, very much like the Aborigines or the Maori in Australia and New Zealand, and women veterans, groups that, frankly, the VA wasn't that good at engaging and didn't look like it was going to engage. Many American women veterans will say, I can't be a veteran, I'm a woman, even if they serve in the combat area. And I suspect this is happening in your nations as well. But again, we were looking for patients to pile into our system. Here's the critical difference. What we weren't thinking about a population health perspective, and if we had been, we would have realized that there are many people involved in VA beyond our clinical staff, and that each of them, including our patients and their family members who are visiting the VA with them, are potential points of engagement with the veteran and other veterans. And each person, including our patients themselves, are potential drivers for improving their well-being and the well-being of others around them. Not only might these people help the veteran enter or stay in care, but they might help the veteran in other ways, like providing social support, transportation. In our state, we've identified trouble with transportation as maybe the #1 access, not only to care, but to having a job, having an income. It's a lack of the ability to get to a job site, let alone a hospital, that interferes with many veterans' well-being and sets them up down the road for suicide. In addition, the veterans can be drivers of information about other services and programs that can be helpful to veterans in general and their families. So instead of seeing the veterans in our hallways and parking lots as just a bunch of patients, waiting online to see us and then go right home, we needed to start thinking about seeing them as the potential drivers of one another's health and of the VA system of care. And then, what about all those individuals outside the VA systems who maybe will never come to us, who might be able to help in supporting veterans and preventing suicide across the nation? In my state, as I've mentioned, 1 in 10 of these people is also a veteran. 1 in 10 of the people in my state is a veteran. And another 2 are immediate family members of veterans, often living with them, many eligible for VA benefits. But we don't ask them to help us, to work with us. We don't ask them how we can help them reach out to other veterans. Many of them are doing it themselves. How can we optimize this system for the greatest possible reach? And not just have one of our VA staff do a circuit ride to colleges. There are so many colleges in my state that the staff couldn't possibly see them all, but work with veterans who are already on those colleges through the student veterans groups, et cetera, to help get this job done. And then finally, what if even a few of these individuals in our system, outside our system, were to band together to work on a chosen activity in support of military members, veterans, and their families? Examples might be to host social meetings in their homes, create support groups within local churches, colleges, or businesses. Maybe it's just a lunch group. Get local government to adopt model policies such as tax breaks for disabled veterans. Help families with a deployed or severely injured service member or veteran. My own plan is to work with small local groups to empower and prepare them to go to their local doctor who's not in the VA system and demand that they, as every patient in their practice, have you or someone close to you serve in the military. And the way I'd like to see this work is that they would simply say, I've been your patient for a while. You've never asked me if I'm a veteran. And quite frankly, I would like you to ask every patient you see this, because you don't know where I served. You don't know what health risks I might have because I served. You also don't know the health resources I have. There are medicines that you might not think I can afford that I can get through the VA. There are treatments, there are diagnostics that I can get that you've probably written off that I'll never get, so you're not going to order them because you think I can't afford them. You know, I don't have insurance, but I can get them through the VA, and not only that, I don't have to pay anything for them. But you don't know that because you never asked me if I'm a veteran. And I'll tell you something, I would never ask this for myself. But if you haven't asked me, then I know there are other veterans coming to your practice, and I'm asking for them. You know, I would never do this for myself, but I'm asking for them, and I'm asking for their families. And I'm going to keep asking you every time I see you. And I hope the next time you will ask me this question. That to me is an exercise that we're trying to kick off here. This would be a population health approach to the problem of deployment mental health and the problem of veteran suicide. So 2019 and beyond, I'm retired from VA. I'm a without compensation employee of the VA, which lets me go on campus, but doesn't obligate me to much of anything, and I can do and write what I like. Joint efforts are underway between Australia, Canada, and the US, and other nations, I hope you'll speak up to yours, to develop a population health strategies focused on the process of separation from the military. Because just like transition out of a hospital is a high risk for suicide period that we can identify and need to develop plans to deal with long before people leave the hospital, transition out of the military, that first year is a high risk time for suicide. And we need to be thinking about how do we prepare people to do that? And essentially, this requires, again, a focus on well-being as opposed to sickness or disability. You all know that if we say to service members a year out, 6 months out, 3 months out, a week out of leaving the military, raise your hands if you are sick, that the vast majority are not going to do that. And military culture mitigates against that being the case. Yes, people will apply for disability at the very end, but you're going to have a hard time really getting them involved. And most of them are going to try not to even think about this. Equally important is an understanding that just as the military had developed sophisticated ways to bring recruits into a warrior culture, there are significant challenges in transitioning from military culture back to civilian culture. My colleague, Paula Davovich in Australia, has written really, I think, important new articles on how this isn't just a matter of learning a few new tricks. This is about a major shift in identity on a par with what Eric Erickson talked about, the maturational crises that everyone goes through in the course of development. But the military to civilian one is one that we don't tend to confront eye to eye, and we need to begin to think about it that way, because it truly is a developmental task. And if people fail in it, it has tremendous impact potentially on their further developmental trajectory within an epigenetic model. So these call for significant adjustments in lifestyle, but more fundamentally in identity itself. And we need to be thinking about how we do that. We're very good at making warriors. We're not so good at making civilians. VA's whole health initiative is the beginning of this. It just so happens, and I think I see it as just a sign of the times. A lot of people are sort of barking up the same tree in different voices through entirely different programs. But I wanted to share this quote with you. This was just released a few months ago, but it's been in planning for at least the last 3 or 4 years. And it came from Tracy Gaudet, who was at the time executive director of VA's Office of Patient-Centered Care and Cultural Transformation. And this is part of literature and websites that are being shared with veterans today. It starts out by saying, during your military service, you committed your life, your health, your well-being to mission success in defense of our country. Now we commit to you, to helping you be mission ready for your life, to optimize your health in the service of what matters most to you. It's a very different message, but it's using a military context, military code words to kind of get people to perk their ears up. You're right. You know, I no longer have a military mission, but I'm still on a mission. And the VA, Dr. Gaudet's pitch continues along these lines. The key question is, what matters to you in your life? And when you're in the military, you know what matters to the military, and you're used to doing it and doing it well. It's quite a challenge to think about, well, what matters to me? Frankly, retirement's about the same. I'll warn you that now. When you think about these priorities, Tracy advises veterans, ask yourself if you're doing everything you can to achieve these goals. The human body and mind have tremendous healing abilities that we can work to strengthen together. Your health team wants to support you on this journey, but obviously your health team can't do this for you or to you. This isn't a traditional health issue in the sense of the standard medical program. Traditionally, providers are focused on what's the matter with patients, zeroing in on their diseases and ailments, but we're working to shift this focus to instead start a conversation about what matters most to veterans. And frankly, it's not the veterans we have to convince of this, but it's our own leadership we have to convince of this, and our own line people who want to hold on to what they've been doing for years. We want to start by getting to know you, putting you rather than the disease at the center of your health and health care. And you see this circumplex, which is a well-being representation. And I was very impressed when I got to Australia. You have almost the same words and the same diagram as we use. Well-being is clearly an idea whose time has come. And I just want to shift in my concluding remarks to say something about the importance of the well-being in perspective. Because I believe that well-being as a concept provides a common language in which veterans, their families, service members, their families, health providers, policymakers, judges, and clergy members, teachers in public schools, we can all speak the language of well-being. We can all talk to each other in very operational terms about well-being, and most of us have some lever that we can pull effectively in the realm of well-being. And you don't have to have gone to medical school and residency and trained in a military or veteran program to understand this. Everybody can talk about this. Everybody can identify the need. Everybody can target a resource or a program to do it. So one of the great aids in this, and it's just a sign again of the confluence of a lot of good people working on the same issues, that there was a recent publication of the Manual for Wellbeing Inventory. And again, this can be shared with you, and I believe somewhere here I've got the website, or we can get it. Dawn Vogt presented on this, and it was Dawn who presented at the last meeting, who was one of the leaders developing the Wellbeing Inventory. So I won't belabor it here, except to say for anyone who missed that, it's a multidimensional instrument to assess status, functioning, and satisfaction in 4 key life domains: vocation, finances, physical and mental health, and social relationships. It's designed to pinpoint strengths and vulnerabilities with respect to key aspects of military and veterans' life circumstances after they leave military service, and it's already been validated in a sample of military veterans. But it may be applicable to to military members throughout their military service, and then throughout their lives in the transition and time as veterans. What's nice about it, it was developed by the U.S. Department of Veterans Affairs National Center for PTSD in partnership with the Henry M. Jackson Foundation for the Advancement of Military Medicine, a group that works very closely with our military and our VA. And it has military as well as VA people working on it and applying it. And this gets back, and this is my last slide, you'll be glad to know, to communities of care. As a critical component of VA and our military's whole health program. And now I'm back to quoting Dr. Gaudet, because I think it's just good advice. You don't have to do this alone, we tell the veteran. Frankly, we tell everybody in the system. Connect with others at home, at work, or in the community to help you meet and maintain your goals. It can be as simple as finding people to talk with, go to the gym, meditate with, engage in a shared interest. When you come to VA, you're not just taking charge of your health, you're becoming part of a community. I won't bother reading the rest of it to you, but these are the kind of messages, but this is what we want people to think about, and we want our own staff and leadership to be thinking like this too. It's a very hard turn for people to make, but I think if we're really going to have the population health system we need. This is the transition we need to go with. This is the next step. And in many ways, we are simply recovering, remembering what we learned in World War I and what worked in its aftermath. Basically, well-being requires a community of care, not just a clinic. It engages transitioning military members in a new mission for life based on their fitness, their healthy relationships, having a place to live, and financial security and the financial literacy to make it all sustainable. And here's hoping we can build on this for veterans now and in the future. And there I'll stop. And thank you for listening to all this.
Thanks very much, Harold. Some really great points that you've raised there, I think. And in a way, it sort of draws together a number of the threads that we've heard in some of the earlier presentations around the wellbeing. And you mentioned Paula, who presented with her colleague Miranda van Hoof, where they raised some of these concepts, particularly around that point of leaving the military and that immediate period afterwards as people adjust to the new circumstances. We've got a comment and a question. I'll start with the comment, and it relates to your point around this involvement of the family healthcare practice. And the comment is this person says they see the involvement of the family healthcare practice being of real value, and their focus on not only individual wellness, but also family well-being, and reaching out into improving the well-being of the wider community. And Paul has just added a comment, which I'll share with you. Terrific presentation, Harold. We really appreciate your insights here in Australia. So there's a couple of questions that come to mind that I'll put to kick things off, and then we'll go to the one on the screen. You talked about, back at the beginning, this issue of that many of the providers who are serving veterans, wherever those providers sit, whether it's within a formal structure or as you have within VA or within the community. And for most of our countries, they're going to be within the community. Lacking the cultural competence and the confidence and their sense of expertise to be able to work with veterans. How much of a barrier do you think it is, the fact that in most of our countries, we don't ask those questions when people seek help? Have you served, or are you a close family member? How much of a barrier is that? Forgetting the point you raised about whether the institution or the person knows how to respond to that, barrier to people getting the help that they need.
That's a key question, Robert. And you know, and it goes back, I've been a doctor a long time, and I look at how do I learn, or when do I change my practice? And, you know, I could read an article, I could be very impressed by the article. It often doesn't change anything I do. I can go to a lecture, including the lectures that I gave more than, 50 times on Painting a Moving Train. And I might say, that was great, what a great meeting, boy, but it may not change anything I actually do. About the only time I ever really change what I do is when a patient makes me aware of something that I should have been aware of and I wasn't aware of. And to me, that makes me think, oh my gosh, I wasn't thinking about this and I should have been. And who else did I miss this with? And then I changed my practice, which is why I think, yes, we need to have a curriculum in all clinical education, not just medical, psychology, social work, et cetera, medical administration. This needs to be taught. But teaching it in class isn't going to get it. We need to practice it. And frankly, this is why I believe that veterans will do more than I'll ever do teaching in a medical school or residency in getting doctors to change their practice. I think we have to make people realize they've missed an opportunity to be of real help. And again, as I was saying, at least in the US, but I think this is true in Australia, where you're working with a veteran who has the standard health card. And if you knew they were a veteran, you might ask them, well, why don't you have the gold card that gives you access to all these other things? You know, I'll help you apply for it. Or I know I'll give you a phone number where you can call and they'll help you apply for it.
Yeah, yeah.
So I think we need to build it into our curriculum. Also, a very nice resource we have in the US, and I wonder if there are parallel things in other nations. We have a nonprofit called Psych Armor that saw the need to educate community providers, saw that the VA is very clumsy at this. Frankly, in VA, I'll tell you, tales out of school, it could take us 2 years to approve and develop and field a curriculum. And then when we field it, it will be large and clunky and too long, and it'll be hidden on some website that if people tried to access, they'd have trouble accessing it. So we're not good at that. And Psych Armor, we're getting better. Psych Armor put up these things. One is like 15 things about the military that veterans would like you to know. And everybody could Google that right now and watch that in 15 minutes. And it's wonderful. So we need nonprofits to step into the gap. We need that kind of training and access to training, and make it comfortable, make it acceptable. Don't guilt people, but get them interested in trying to do more than they've been doing.
I think that's a good point that you elaborated later in your presentation to that one, that actually this needs to be something that's owned by a wider bunch of folks. And in fact, you put it where I personally agree with you. It's the community's responsibility, however you define the community, that it's not just one entity or the government through Veterans Affairs or the government agency is wholly and solely responsible. So, which leads into the first question that came up on the screen here, and while it relates to a particular country, the core of the question is where we want to push, or by government policy or design, or in whether it's intent or just happens coincidentally, where these people are being pushed out into the community care and out into mainstream services. What, if any, concerns do you have about that approach? And they say the message is being sent, I guess, to veterans and their families, but also to community providers. I turn the last bit around and what help perhaps do we need to be giving community providers to be able to accept responsibility to provide high quality care and support to veterans as they come into their orbit?
Well, thank you. That's one of the questions of the hour. And interestingly, if you were to Google the United States Mission Act, the Mission Act it's called, it is a law. It's in force. It's been in force for about 6 months, and it'll go way into the future. And it's about exactly this. And the way the law is written, the law says that veterans should be able to access care where they want it, when they want it, VA, non-VA. If they're eligible for VA care and they choose to access it outside, the VA should pay for that. But the VA should also make training available. It should figure out ways to monitor the quality of that care. It should ensure that it is militarily, culturally, and clinically competent. And it should create systems in which there's ongoing learning, you know? And that's all ideal, but the implementation is the challenge. So that we're beginning to see new courses being developed right now as part of the Mission Act that will be fielded, and we'll see if they're watched. We'll see if people say they liked it and learned from it, but mostly we need to see if they've changed their behaviors. And if they haven't, we need to find ways to assure the real measure is, did you change your behavior? Not did you take the course or did you like the course? And too often evaluation ends there. So that's one big part of it. The other thing about the Mission Act is I see it as a game of Russian roulette. A lot of the people in Congress who sponsored the Mission Act believe that the VA shouldn't exist at all, that the VA is a government healthcare system and therefore a bad healthcare system and a bad precedent in a nation that's many of which leaders are trying to resist national health. So what they want to do is send all the money out into the community. But what this does right now, if we simply paid for community doctors, we know, and the RAND study has shown this, we know that we would be creating unequal systems of care, both paid for out of the same bucket of VA money. And that the more we sent this care in the community and sent VA funds out, we would have to shutter VA clinical operations to pay for less comprehensive, less competent operations in the community. So the Mission Act is a gigantic gamble. If it succeeds, and we do it the way it's written and the way it sounds like it's supposed to be done, we won't engage these outside doctors, social workers, psychologists, marriage and family therapists, unless they agree to take training, complete the training within a unit time, and demonstrate that they're practicing the way they were trained to practice. That's if we do it well. If we do it badly, the money will just seep out in every direction. The VA will eventually starve itself and be shuttered. And those who didn't believe in government healthcare will be able to point to, oh, look, those guys bankrupted themselves. We knew this would happen sooner or later. And they were no good to begin with. And it'll take another major war before enough veterans get together and say, fix that.
Yeah. One question that I have to pose to you coming out of that is, we have the need to educate current clinicians and allied health and associated professionals are working out there already. How important do you think it is that we start to engage institutions of higher learning that are training the next generation of clinicians, whether from medicine, nursing, allied health, social work, wherever they are, to actually have as part of their undergraduate and postgraduate training modules around veterans and families' health and well-being as part of their base education. What's your thoughts about something like that?
It absolutely needs to be basic curriculum. So somewhere in my slides, and I probably jumped right over it, if there are 20 million living American veterans, another 2.5 million currently active duty, and another, I don't know, a few 100,000 reservists, and conservatively, they have 1.5 dependents each. We're a nation of 300 million people, and somewhere between 50 and 60 million of them, 1 out of 5, more or less, are either service members, veterans, or their family. And yet, those people are totally ignored in our health systems. Our electronic health records, the commercial ones that our major training institutions use, most of them actually have, I found out, a field already built in to identify veterans. And I'm not sure about military families, but definitely to identify veterans. But when they sell these systems in the default mode, these systems aren't turned on to register that. So we have that problem. The Association of American Medical Colleges, or maybe it's the American Association of Medical, I never get it right, but we've been working with them for years, and they put their shoulder behind it. We developed model programs. We did national teaching webinars during Veterans Week in America. We did 5 days. We had medical students, many of whom were veterans, and were now medical students, former Army medics, Navy corpsmen. It was impressive. It was inspiring. It was wonderful. Not that many people took part. And what we found is that this national overgroup that supposedly is responsible for the quality and communicating and coordination of American medical education doesn't have the authority to make anybody do anything. All they can do is write newsletters and send people letters saying, why don't you do that? And in fact, it didn't diffuse. At my own medical school, when they responded to the invitation that we helped create at the national level, the dean said, well, all of our medical students are rotating through, and residents rotate through the VA at some point. And by the way, the United States Department of Veterans Affairs is the largest medical education program in America. 1 out of, I think, 4 health professionals in America have trained in some way here. But he said, well, since they were there, they know all about this. And of course they don't. They don't learn all about this. When I was a medical student, I worked on the ophthalmology service at a VA hospital. I didn't learn anything about veterans. I learned about eyes. So bottom line, we need ways to do this. Now, one of the best ways to do it, I think, because I know health professionals are caring people, and they're smart people, but they're also a little afraid of looking like they don't know what they're talking about, being smart people, and and they get anxious when you approach them with something they don't know. I think one great way to do that, and where we have the manpower to do it and the reach, is by training peer support specialists. I said we have fortunate to work in the VA. We could be getting those people on the road and going to doctors' offices, giving talks at medical societies. I frankly think those people are going to be more easily listened to than I will if I come and preach. And as I say, I love this idea. My wife used to sell Tupperware. I'm not sure Tupperware is sold all over the world, but the way they sell this plastic packaging material for housewives and house husbands is they arrange little parties and invite your friends. And it's amazing how many people end up buying Tupperware across the community, because all Americans have some Tupperware, it seems to me. And this really worked. So I'd love to see Tupperware parties, but instead of Tupperware, they're meeting to talk about how are we going to get this from our community. And I invited you, and who are you going to invite to your kitchen and sit around your kitchen table and do this? And which doctor's offices are you going to that they never asked you? And what are you going to do about that? The way the United States Department of Veterans Affairs was invented, the way it was developed, is not because government thought it was a good idea and we're going to go out there and do it. It's because enough veterans and their families complained that the military sent people back from World War I without any health system that was capable of meeting their needs, either in terms of capacity or competence or training. And that was wrong. And they had to do something. And it took several years before government responded to that. We need that again.
Thanks for that. I got a comment from Dawn Voigt, our joint colleague.
Yes.
She says, great presentation and really interesting history about how the USVA's approach to addressing veterans' needs has narrowed over the years. And that's a good segue, because I noticed that was a question that I was going to ask, because I noticed when you talked about that, how that there are, and I think this is common across the 5 Eyes countries, is that we, over time, have moved with a loss of capacity, this is my words from what you said, and recognition of the complexity of veterans' issues and the interrelationships. And we've moved purely to the narrow, you called it clinical models of care. I call it to the immediate issue sitting in front of me right now.
Yes.
So I know that you sort of spoke about some issues around that, but I was wondering, in the light of Dawn's comments there about, and you talked about some of the work you did in North Carolina, but how can we more broadly, as advocates, and I use the word advocates in a generic sense, start to maybe put this on the agenda and get people in policy and leadership roles starting to talk about this and to explore how we might change that dynamic, or do we need to change the dynamic even? Is it okay that we just purely come down to the narrow bit of what's in front of us? Or do we need to have that wider recognition of the whole context and the complexity that might bring?
Well, I'm not saying that I'd like everybody to do this, but I'm not saying everybody can or will or should. And I'm very proud of being a psychiatrist. I'm very proud of what I've learned, and when I can actually help people through the skills that I've spent a lifetime trying to develop. And yeah, that is enough within the context I was in. But I've often had the sense in the last several years that I used to go home from work thinking, well, I saw everybody in the emergency room. I saw everybody who was scheduled to see me. I answered all the phone calls. I did all the charting. and I'm dead tired and I'm here too long and my wife's annoyed with me because dinner is on the table, but damn it, I feel pretty good. I did my job and the world is safe. And that it never occurred to me that the majority of veterans who might need the same help that I was helping these guys with, and women, weren't even in my system. The job wasn't done. And I think that's the way to think about it, actually. And then, like I said, that time I stood up and said, there's a public health problem. I don't know anything about public health. I didn't even know any public health people, and I couldn't find them in my system, and none of them were in my hospital. But I did find over time that the VA had an office of public health. I didn't know that existed. Now it has an office of population health, and partly because of whining on my part. But what I did is I eventually found that there were people who liked this stuff, but they were off in a little corner and they were counting the widgets they were assigned to count. And they had expertise to understand and frame these issues in a new way and to cooperate, to combine their efforts with clinical people. Nobody had ever asked them. So part of it was go knocking on doors. Who are the people who know this stuff? Part of it was going to the School of Public Health and saying, look, I've had my experience, you've had yours. We didn't study in the same schools. We don't know each other. We don't go to the same meetings. We don't go to the same grand rounds. We don't read the same literature. We're not aware of the same research. But could we help each other? And could we begin to create the crosswalks? Could you come and present with me at the International Society of Traumatic Stress? Could you come to my VA mental health meeting and talk about the public health model and what it really means to do public health work and how we even design a public health program? And we did this last week in Washington at this national meeting on suicide prevention. We had public health leaders from our Substance Abuse and Mental Health Services Administration, SAMHSA, which is in charge of mental health policy and to a certain extent, making sure it's being implemented around the country. And they challenged us. What are you going to do about suicide when you go home? And we worked with methodologists and public health experts to say, we're going to develop comparison trials where we go to one city and do this intervention, and we go to another city, we get the same baseline data and the same follow-up data, but we don't do the intervention there. And we're going to see if it makes any difference in terms of the number of veterans identified in this health record of this major medical center in that city, if it makes any difference in terms of the care accessed, if it makes any difference in terms of outcome measures that we can access, and if it makes any difference in suicide. Now, a year in one city may not be enough to get any signal, but it's something maybe we can follow. And let me just throw in something. And again, this is the irony of, well, I spent my life doing one thing and I thought I was doing it well, but oh my gosh, maybe I wasn't. We know from VA data, and VA has the best data in our country on suicide rates among military and veterans. It was nobody else's job to do this, and nobody else bothered to do it, which is often the case about military issues and veteran issues. And they all think we're going to do it because we're the VA. So we did it. And I can now say state by state, region by region in the VA what the rate of suicide is. And I can tell you that in 2019, well, based on 2017 data, the latest that we have that we've cleaned up and analyzed, North Carolina, my state, has the lowest rate of suicide in its region of states and a significantly lower rate of suicide than the rest of the United States. And I've heard some of my colleagues, when I got back to North Carolina in the governor's work group, say, that's because of what we did in the governor's work group, of these partnerships, of the referral base, of our enlightenment, and our reaching out and enlightening people. Well, the real tragedy is there's no evidence that that's true. And we didn't build in a system to evaluate it as we were building it. So yes, it would be great to think we were responsible for saving lives through suicide, and imagine, the impact of that. But there won't be anything on the shelf for the next war that says the evidence tells you if you do this, this will prevent suicide. And the next generation will have to invent this themselves, and maybe they'll prove it. Or maybe they'll be just like us and won't, be busy acting in the moment and won't take the trouble to design a system that will create an evidence base for the future. It's thinking like this, but again, I was never trained to do it, so I don't feel that guilty, but I feel pretty guilty that I didn't understand this 15, 20 years ago.
It's interesting that comment you made around that suicide stat, and you talked about North Carolina. My mind went back to the presentation by Carl Hamner a few weeks ago, and I don't know whether you caught Carl's presentation, where they're halfway through their 4-year review, and he talked about hotspots suicide. And one of the questions, as I recall, that he was asked is, what were the characteristics of the hotspots? And essentially, they were the opposite to what you talked about, what you did in North Carolina. They were communities where there was poverty, but also dysfunctional communities where people weren't connected, organizations weren't connected, the communities didn't work very well. So maybe while you don't have direct empirical evidence, maybe through other things, that as we join the dots around some of this, we'll suddenly see that actually North Carolina, in your case, was actually really inspired to create this capacity that supported people who are vulnerable, where those supports were actually out of the community, not out of someone that was tasked specifically to watch out for that bunch of folks.
Well, I want to believe you're right. Let me also mention that Carl Hamner attended one of our Painting a Moving Train programs years ago, and immediately called us up and started working with us. And it is an example that when you get people like Carl who have the energy and already have a job that, you know, makes them aware of the kind of issues, but then then a light went on in Carl's head, and he's been working on this ever since.
Yeah.
I won't take full credit. It was fertile ground, but it goes to show you that if you throw enough seeds, some of them are going to sprout.
That's right. Well, we've got another question online here, Harold, and it starts by saying, thanks for an edifying presentation. And the question is, how do you see such common sense approaches to well-being and community collaborations being integrated into clinical practice guidelines? And this person's working with PTS, I think, for PTS. So I might modify the end by saying into clinical practice and for whatever mental health condition that the individual or the family has.
Well, you know, right now, the literature on peer support isn't strong, but it exists and it's growing. I've been on several clinical practice guideline development groups, including I was the lead for VA in the first VA DoD practice guideline, which ended up being the model for the Australian guideline. And I remember working with Mark Kramer and people in Australia kind of, you know, well, look, sure, you can have what we have and good luck. And by the way, I want to say that the Australian guideline, I envy it at this point. I think it's much more balanced. The US one has become very reductionistic. But I think it's the reductionism you're talking about. Unfortunately, in the world of evidence-based medicine, you know, if it wasn't in not just the right meta-analysis, but the right journal, it doesn't end up in the guideline at all. And I think we've put precision and methodology, you know, at the center of everything. And we've lost track of the practical. We've lost track of what actually happens in clinics. We ignore the fact that the groups selected to be in these studies tend not to be highly representative of the group of patients we're actually treating. And we lost track of the fact that in the clinical world, a lot of fuzzy things happen all the time in real time, and you have to respond. And I think those things by themselves, I'd like to think, would make the argument that there ought to be a subsection in every clinical practice guideline about well-being, about using a different lens, about there are people you'll never engage by talking about their pathology. And you mentioned PTS. The idea of PTS was it's not a disorder, it's only post-traumatic stress. And people will be proud to have post-traumatic stress, that would be embarrassed to have post-traumatic stress disorder. I think well-being takes that to the next notch. They don't have to be sick at all. And to challenge clinicians, does your system have that engagement piece, which frankly might engage a much larger group of people who, if not now, soon may need your help, or ultimately may need your help. and you can do the upstream intervention. What are you doing upstream? And I think, I also think that if every medical center did Dawn's well-being inventory, and Dawn can speak this much better than I, it may be that as we get more data, we'll be able to develop a quick screen, you know, like the PHQ 9 for well-being, and then do a fuller screen if there's a signal, but we have to get a lot more data, I think, before we get there. If all clinical services incorporated a well-being screen, and this can be done again by peer support specialists because it is plain English. In all the 5 English nations, you know, George Bernard Shaw, you know, we're 5 nations separated by a common language, but I think even peer support specialists could do this screening. I think we'd be much stronger as a health system.
Thanks for that. Bernadine and the crew at Veterans Affairs in Wellington, you've been very quiet. Just wondering whether you had anything that's resonated this morning with you that you might want to ask Harold or put to Harold.
Sure. This is Dan here. Can you hear us?
Yes.
Pretty well.
Lovely. So I'm one of the rehabilitation advisors here. Just wanted to say thank you on behalf of everyone here in New Zealand for your presentation. It was certainly quite enlightening, and one of the things that was going through my mind as you were talking was actually here we have possibly some of the opposite factors in terms of reaching populations and communities and regions, because we have a much smaller general population and obviously a much smaller percentage of military personnel. So what was going through my mind was wondering if there are ways in which we can accentuate the positives of being a smaller nation and a smaller population in accessing such peer support and yeah, a public health perspective. So that's, I guess, really more of a comment than a question. Is there anything else you'd like to add, given that we face different kind of issues with managing smaller numbers?
Well, let me respond to that, because I you know, and pardon me, I hope I don't embarrass myself by talking about stereotypes. I don't know nearly enough about New Zealand, and I want to. but what I've learned from people who are New Zealanders is that small population is also a highly interwoven one. And there's a very strong warrior culture through the Maori, which even New Zealanders who can't trace themselves to the Maori are very comfortable with. It seems to be a national characteristic that, at least in the very few people I've known from New Zealand, and I think that there are probably wonderful ways to follow the threads of that culture, whether it's through youth groups and summer camps and social clubs and shooting clubs and, you know, veterans organizations in communities that could move this forward. And in particular, invite veterans to step out of their role, which is often made passive by experts like ourselves, and frame their own agenda and even frame their own plan of what they'd like to do about it, and get everybody together to think about, well, how can we do that in our community? What resources do we have? What resources do we know about in Auckland that you don't know about in Christchurch? I think some very energizing conversations and new leadership. And I go back to my experience with somebody like Carl. Carl says, my gosh, I was thinking about this. We just came to this meeting, it sounded interesting, and I got to do something. And there was no end to what Carl could figure out what to do. And he knew things to do in Alabama that I had no idea were even possible, you know, or that a state could do. So I don't know, that's my response to the very good question you asked.
I think, Harold, it builds to something that I was going to come back to, but it's great that the question's been asked, is because I think this is really around that proposition you put to us about how do we engage communities, which is all the organizations, government, formal, informal, individuals, family groups. How do we engage them around, and I'll use this word, starting to own this, and developing things that are particularly relevant to that community, however they want to define. So do you want to look at that, and New Zealand is a great place from the point of view, and you raised that Maori culture about how do we also engage. You talked about some of those non-traditional areas that we haven't really thought about, Indigenous veterans, women veterans, etc. What do you think might be the opportunity to build on this point for New Zealand, but I think we can all learn from? How might we go about doing that? What are the elements in that, from your experience, that makes that work?
Well, things that I've seen work very well, we'll talk about engaging, say, Black veterans or women veterans. There are groups of Black and women veterans. There are veterans groups on almost every campus in America. But until we started talking with them, it didn't matter, and it didn't matter that we existed to them. So that was a big part of it. Our military actually works with the Boy Scouts of America, and our U.S. Department of Agriculture created something called the 4-H Club, which has a military child subgroup. I've mentioned the Military Child Education Coalition, this nonprofit group, although the leading people in it have included the wives of the chairman of our Joint Chiefs of Staff and the head of the National Guard Bureau and people like that. These groups, the Military Child Education Coalition, has said, we want to reach military families by reaching their children. And we want to start by asking every school system in America to simply ask the question, and by the way, this is where I got the wording of my question. Have you or someone in the family served in the military when you register for school? Because, military people, at least in the US, have these permanent change of station, new postings on average every 2 years. That means their kids are registering in a new school. And that means every time they move, the school may or may not know that they're a military child, but there's an opportunity to find out. And then they can reach the kids. And one other very concrete example, but a very important one, is congregational leaders. Our military have wonderful chaplains, not enough of them, but wonderful ones. Our VA has its own chaplain service, many of whom are trained in clinical pastoral education, something that I think has swept the world in the last few years. I don't know if you have these programs in other countries, but I believe you do, where people who come from the clergy background get special counseling training to complement this. Again, not necessarily to become mental health professionals, some do, but just to be articulate and to know how to point in the right direction, know how to recognize a problem and how to talk about it. What we found statistically is that veterans are 5 times as likely to talk about a problem in readjustment, or a problem coming back from deployment, or a problem during deployment with a member of the clergy or a lay leader in their congregation than they are with a mental health professional. So, and we've also found that while clergy resist doctors coming out and saying, do what I do, because frankly, we don't know what to tell them anyway, and they don't understand what we're talking about. They're very polite, but they tell us later, that was really nice, I'm glad you came out, but I have no idea what to do now. But when we send our chaplains to the community to do these trainings, they talk the same language, they have the same priorities, they understand each other's philosophical grounding, and how they approach the issue of war and trauma and loss. And this is effective. And we actually have some model programs in the US, which I'm sure the developers would be glad to share, that reach out to clergy. And that's a great way to get to a small community. Homelessness, finally, is another. If you have as much homelessness as we have, but we actually have a law that says every homeless program in the United States at the state level has to collect information about being a veteran, but it can't, but at least in our state, they're not allowed to share that with the VA because that violates the confidentiality of the veteran. They're just doing that for statistical purposes, and you can't operationalize that information. So we've worked to change the law, and we haven't succeeded. And we're still working on how do you take the data that's already in our systems, like homelessness, and find people who, frankly, are pretty low already on the slide towards suicide because they burned through their resources. So it's like that.
Thanks for that. We've got another comment / question. And the comment is that what you're talking about seems to be all about restoring agency at the community level. Agency and identity are inextricably linked through the concept of selfhood. So a solid sense of self is associated with good mental health and good well-being. I guess that resonates with me, that observation resonates with me, because you alluded to it, and I guess it goes back to the thing about the purely clinical, where the approach has been leave it to the professionals, mother knows best type approach. How important do you think it is, and again, coming back to where you talked about this community capacity and your response to the New Zealand question, around actually about the importance of building agency and ownership, both at the community and the level of the individual. How important is that, do you think, to achieving some of these outcomes, of positive outcomes in health and well-being?
It's absolutely key, and I commend again Paula Davidovich's writings who really does a great job of approaching this, and I think it's a growing literature. Look, a lot of veterans coming back to the U.S. on their own started groups that respond to disaster, and these veterans get together and they have a lot of skills that are good in the disaster area, and when something bad happens, they mobilize and they have a mission, but that mission only exists when there's a disaster. And it does give them a sense of agency and a sense that they know something other people don't know, and they're very good. Frankly, I remember in a hurricane here in North Carolina that was truly devastating. It almost destroyed an historic community. A veteran I worked with terrible PTSD and depression and always at risk of suicide went and volunteered. And I remember he told me he looked in the eyes of this lady who answered the door when he knocked and offered his help. And he saw in her eyes the way he feels he must have looked to everyone else for the last 40 years. And he realized that in this world, this traumatized, disaster-stricken world, he was suddenly the competent person. And the average American was incompetent and unable. But because he had lived, he'd walked in those shoes so long, now he was competent and he was on a mission. And I think the idea that I'm offering, whether or not it ever proves to be helpful, one of the reasons I talk myself into thinking it might be, is I think people need a mission they can do every day. And I think we need to say to them as professionals, we value your experience as a veteran. We value your cultural competence. You can do things I can't do. I have an MD, but I can't do what your fellow veterans need you to do. And I hope you'll accept this mission. And I think that is militarily, culturally competent on our part. and I think it reinforces that sense of agency. And for some people who had lost track of being good at anything or having any identity, just felt like a misfit and decided maybe I was always a misfit, if they get a chance to help another veteran, or even just connect with another veteran, it's a very powerful reminder and reinforcer of that core identity that isn't really gone, but needs a spark. So I want to find ways they can do that every day and not just when there's a hurricane.
Well, I think we're just about out of time, and I think that's a really great place to end in a way, because that quote you gave us, I think, really sums up both what you were trying to share with us today, but also what we're trying to do through this webinar series, and which was to be mission ready for your life.
Yes.
And to optimize your health and well-being in the service of what matters most to you. And I think that's a great summation, both for the individual, both for us as organizations and entities that are working with that population. But it's also a great guiding star in a way, I suspect, if we're serious about what we do, to be able to use that as our touchstone and ask ourselves, if we're supporting that community, how well we're going. Because if people aren't able to say, well, I am mission ready and I am able to optimize it, then maybe we're not doing such a good job. So I think that's a great summation of not only your presentation today, Harold, but I think of what we're all trying to achieve. And the other takeaway I think that I take from today is that we need to look at this through a broader lens of a population health approach. And the key to that is that community is critical. That building that community capacity is critical. So I want to thank you on behalf of all those who've joined us today, and also those who will watch this later as a resource for your contribution to the discussion today. It's great to have you contribute, and we look forward to having you contribute as we continue the conversations around this topic over the next few months and wherever it may ultimately lead. I'd like to end by just reminding everybody that next week we have Dr. Shelley McDermott Wadsworth joining us, and we're going to start to broaden our focus, if you will, and she's going to introduce us to start thinking about the topic of military families confronting stress and in transition. So helping us start to understand the particular issues that group of folks that Harold spoke about today, who have their own challenges coming out of military service. So I hope you'll be able to join us for that session next week. So thank you, everybody, for joining us today, and I hope that you have a wonderful rest of your day today, and we look forward to having you join us when next we convene.
Thanks, Robert.